الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم جميعا. Dear colleagues, ladies and gentlemen, it gives me a great pleasure tonight to welcome you here in the 5th IMC Family Medicine Club under the umbrella of the Saudi Society for Family and Community Medicine. And I would like to highlight the strategic partnership between the IMC Family Medicine Club and the Saudi Society for Family Medicine, with a very important objective is to enhance the capability of the primary healthcare physicians, family physicians, general practitioners, and others healthcare team who are working in primary care to sharpen their skills and to update their knowledge about all the important topics and important challenges that they encounter on day-to-day practice during their serving patients in the primary care. And we would like to make sure that and reassure you that within the very short period of the club, which we started last year in 2020 March till today, on monthly basis, we have been striving to conduct one event that is related to one of the important topics that's related to our practice. And we invite a very unique and high caliber, very prominent, eminent speakers in that specialty, having the specialty of our family medicine along with the subspecialty combined together to enrich our scientific event with a lot of updates, knowledge, clinical guidelines, and more important, how to integrate the different types of multidisciplinary services to be provided to our patients in the setup of the private healthcare setup. So with this, I would like to thank all of you for attending today, and I would like to thank all our guest speakers who have been enriching us, with their presence and to add a real value to upgrade our knowledge and skills in the field of a very important topic, which is the musculoskeletal pain management. And I would like to thank Asino Company, who are sponsoring this event. So thank you very much. And I would like to extend my thanks to the Forum Experience for Exhibitions and Conferences for having their platforms and organizing this unique scientific event. And ladies and gentlemen, I would like to welcome here our guest for tonight, who is Dr. Sami Eid. He's a consultant family medicine, and he's the Director General of the Office of Jeddah for the Saudi Society for Family Medicine and Community Medicine. And I'm sure that he's exerting his effort to enrich all the people who are engaged with us, in this kind of scientific event with a lot of activities. And one of it is our club, which is going to be under the full support of the Jeddah office for the Saudi Society. So I will leave the floor for Dr. Sami Eid to give us a small brief about the Saudi Society Jeddah office. Dr. Sami, the floor is yours.
Thank you, Dr. Ashraf. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Thank you very much for this invitation from Dr. Ashraf and from you. And it's my great pleasure to participate in this meeting and a professional meeting. And actually, I would like to thank the speakers and everybody. And also the main thing for the Dr. Ashraf and the IMC, as they are sponsoring this meeting. And thank you also for the companies that associated with this meeting. Actually, I would like to talk about our office, about the Saudi Society of Family Medicine, the Jeddah office, especially, because I'm responsible for this office. Actually, as you know, that Saudi Society is one of the oldest societies or scientific societies in Saudi Arabia. And as you know, that is since 1411, they are initiated at that time. And we have 12 offices, and one of them is the office. And we would like to invite you, to participate with us and share with us to the membership of the Saudi Society. This is actually it's a great pleasure for us, if you just come and just register. As you know, that we have a lot of goals that are looking for, objectives that we have looking forward. One of them, it's just to increase the health education for everybody, and this is for to have a lot of campaigns or educational health educational campaigns. Besides that, also we are doing some, it's like encouraging our candidates, our members, those family and community doctors, and everybody, even the primary healthcare doctors, to just in the training and help them in the training, in the researches. Just for that reason, we just need more encourage to us to participate and to be with us in these meetings. Actually, I think here I have given those organizers the paper that, or just the form that we can do it for registering in this office. It's help us actually, and it's try to build our ourselves and to be more motivated to have a good communications with our doctors. This is actually, I don't want to be talking more about that, but I think Dr. Ashraf, maybe because he's the co-president for the society, and he's I think more have more knowledge, and he's more in these issues. I have to give him the chance to talk about that. Thank you, folks.
Thank you very much, Dr. Sami, for being with us here. It's a real honor to have you with us here. And I'm sure that the Office of Jeddah for the Saudi Society has been very, very active office that has been conducting a lot of activities, scientific activities for the primary care physician, family physician, and all the members of the healthcare team, in fact. And there's some conductions of certain community outreach program, because our role is also to reach for our community with health educations and the international awareness days in different specialties, as well as the research and others. So I would like to thank Dr. Sami for being with us here today. And ladies and gentlemen, let me go back again to remind you of the membership that will be displayed, the email at the end of the sessions. So you can send your applications and your requests to the email, and ultimately you will be answered by the format will be given to you, and then you can get the membership of the Saudi Society for Family and Community Medicine. So ladies and gentlemen, I would like to remind you that our sessions, we have been privileged today to have two eminent speakers, Dr. Badr bin Hamid. He's the chairman of the Family Medicine Department in the International Medical Center, and he's a consultant in family medicine. He's going to talk about the musculoskeletal pain. And also, we have been privileged, and we would like to be very grateful and thankful to Dr. Sami Bahlas, who's a consultant in rheumatology. He's going to talk about another important topic, which is approach to the adult with polyarticular pain. And we have Dr. Tamer Harbi. He's going to talk about acute pain management between efficacy and safety. So I think our session is quite rich, and it's full of a lot of important topics and issues that will be of a very interest to us. So please, I would like to urge you to put your question and answer in the chat, in the question Q&A box, So I'll be able to carry it along with me to the speakers, and we will have it at the end of discussions. But ladies and gentlemen, let me have a small introduction just to let you know how important is the musculoskeletal pain management in the primary care. As you know, it's a very common cause of disability, and we have come across a lot of cases that have been converted from active patients or individual into a completely disabled patients. And it's very commonly managed by the primary care. And one of the statistics showed that about 15 to 20% of those patients with the musculoskeletal pain, they constitute the populations of our day-to-day practice. So it's quite prevalent for us, to have this huge number of patients coming to us to seek the pain management for musculoskeletal pain. One of the study which is very important, and I would like to deliver to all of you to let you know that we are very important healthcare provider sitting in the front line as a gatekeeper for the healthcare system, managing almost 50% of the pain of the musculoskeletal pain in the primary care setup. So only 50% can be referred to the subspecialty. So the management is not only actually non-steroidal anti-inflammatory, but the management, as we know, as family physician and the primary care, it should be a multidisciplinary, it should be a holistic, it should be a patient-centric, it should be also a biopsychosocial model that you encounter not only the physical component of the pain, but also you go all the way to address the psychological and the social impact of that pain on the patients in order to have the holistic modalities of management of pain. And of course, we deliver educations and improve the quality of life of patients. We do a lot of lifestyle modifications in order to have a supportive added on therapy to the non-steroidal anti-inflammatories. And we are looking into the patient in total by a personalized patient-centric care. So please keep in mind that when we treat patients, we treat them as one entity, not into a fragmented pieces. So with this, ladies and gentlemen, without any further ado, I would like to welcome our first speaker, Dr. Badr bin Hamd, who is a consultant family medicine and the chairman of the family medicine department in the IMC. And his talk will be about the approach to adult with the musculoskeletal pain. I'm very sure that you are going to have a very interesting, very rich session that has been touched with the reality of our real world practice of pain management in primary care. So Dr. Badr, thank you for accepting our invitation, and the floor is yours.
Okay, thank you, Dr. Ashraf, for this great introduction. And I would like to thank the organizing committee for organizing this scientific event and giving us the opportunity to present today. And I hope my presentation will be comprehensive, practical, and meet the audience expectation. So, Bismillah ar-Rahman ar-Rahim. Our objective today is we have four main objectives. So, first of all, we'll have some introduction about the musculoskeletal pain in general. As you know, it's a very huge, big topic, and we can talk about musculoskeletal pain in many lectures. So, we will try to make it comprehensive and practical as much as we can, inshallah. And second objective is to review the anatomy in general about the musculoskeletal organ and system, and to explain the approach to musculoskeletal pain in the primary care and from family medicine point of view, and finally to discuss the management of musculoskeletal pain. Muscles, joints, ligaments, and tendons are frequently the site of trauma and inflammation, in addition to other disorders like degenerative disease, arthritis, and tumor. It's a common complaint among adults presenting for medical care. In fact, nearly everyone, regardless age and sex, will experience muscle pain or soreness and joint pain at some point in their life. And this is our practice daily in primary care, or even in family medicine, and in hospitals, or even in other clinics. Excessive exertion, trauma, and viral infections are among the most common causes. While many causes are benign and self-limited, pain may be the harbinger of disorders associated with significant morbidity. The family medicine or the family physician should be competent enough to evaluate any musculoskeletal pain by taking a proper history and performing complete examination, then using his clinical judgment to decide about the management and possible referral. So here we can see the common musculoskeletal pain site, and this is what we are seeing in our daily practice. Mostly, if we think about the site from above to down, so it could be cervical, and most of our patients presenting with cervical pain. It could be cervicalgia, cervical disc, muscle tension because of the lifestyle. Second side by going down, the shoulder, it could be a chronic or acute, it could be inflammatory, it could be due to trauma, especially if the patient is young, and we are going to discuss more about the differential diagnosis. Going more down, it could be back pain, which is one of the most common musculoskeletal pain that we are facing in our clinic in family medicine, and mostly it's chronic pain rather than the acute pain. And it's very important because we need to pay attention to the red flag regarding the age, regarding the associated symptoms. And then after that, we will go to the knee, which again, it's one of the most common, either unilateral or bilateral, and we can see knee pain in all ages. Okay, we're talking about the young age, mostly because of sport causes, going to the extreme of age, like 50 or 60-year-olds. Okay, it's most about osteoarthritis and other degenerative disease. And going down again to the ankle, which is again one of the most musculoskeletal disorders that we are facing in all ages, ranges from fracture, tendon inflammation, tendon rupture, okay, to the most common presentation, which or disorder like plantar fasciitis. So all of these are the most common side that we should pay attention, that we should master it very well, how to take the history, how to do the examination, and how to approach the patient. And finally, I put here generalized pain again. We are facing this a lot. Most of the patients, they will come to us, either young or elderly patient, they will complain about generalized, okay, body ache. And it will be like a dilemma for us, a gray area for us. Generalized body ache, generalized muscle pain associated with fatigue or other symptoms. It could be a simple thing, it could be a serious thing. That's why we need to approach our patient properly. So one of the important points that Dr. Ashraf mentioned here is that it is not about the pain, it is not about the person himself. There is an impact. The pain has impact on the patient and his family. So the impact is not only physically, it has psychological impact, sometimes it has social impact, and sometimes it has financial impact. The patient will come most of the time because of the pain. The patient will have multiple visits to family medicine, to orthopedic, to rheumatology, to pain clinic, to physiotherapy, chiropractor. So the patient spending money, spending time, spending effort, okay, because of the pain. So controlling the pain is an important thing to the patient. If the patient is elderly, so he will not be affected alone, so his family also will be affected, his work will be affected, as we will see here in this figure. So it's not about the patient, it's about his family and his work. But we should, as a family physician, we should consider all of this dimension when we are dealing with pain, whether it's chronic, whether it's acute. So coming to the practical part, how to approach patient with musculoskeletal pain. As any disorder, as any problem, we need to have a scheme in our mind. So this is the scheme that we are following in family medicine, starting with a problem, which is a muscle pain or joint pain, thinking about differential diagnosis broadly, then using our history and examination, we will know the differential diagnosis, and by doing the interpretation, we can manage, or we can come to some diagnosis, and finally, we will talk about the management. This is the general approach for any musculoskeletal pain. Before talking about the approach, it's very important to keep in mind the anatomy of the musculoskeletal system. Okay, starting from outside to inside, and the knee here is an example, starting from the skin, subcutaneous tissue, muscle, bursal ligament, and including the bone, muscles, and ending by the synovium. All of these are the structure of the musculoskeletal system that can be affected. So any one of these structures can be affected, and any one of these can be the site of inflammation or site of infection or site of trauma, as we can see here in this slide. So this is the main categories and classification of the of any musculoskeletal pain, starting from the double I, which is infection, inflammation, double T, which is trauma and tumor. It could be degenerative disease. Sometimes it is a referred pain or neuropathic pain and mixed as a muscular pain. Sometimes it's if the pain is acute and severe, it could be something vascular. Sometimes the pain is due to medication like statin. Sometimes it's one of the symptoms of endocrine or metabolic disorder like hypothyroidism. It could be due to autoimmune condition or systemic conditions. The simple or the most common presentation or cause or category, which is the overuse or malalignment, muscle flexibility or strength, and psychiatric. I put psychiatric at the end because we are facing case. We believe that the psychological status of the patient can present as muscle pain, like patient with generalized anxiety disorder and patient under severe stress. Sometimes it can present with generalized pain. And one of the main musculoskeletal problem that we are facing, and I believe it's underdiagnosed or misdiagnosed sometimes, and it's related, it has many factors, and one of these factors is stress, is fibromyalgia, and we'll talk about it later, inshallah. So we have many categories of many classification for musculoskeletal pain. We need to narrow this. We can narrow these differential diagnoses or put this classification into simple classification by classifying the pain in general to acute and chronic. So acute pain, which is a pain less than 6 weeks, it's mainly, if you want to choose from the previous slide, it's mainly due to trauma or inflammation or infection. If it's chronic, it could be inflammation and trauma, and we can add degenerative and tumor. A muscle pain, it's very important to classify it. Is it localized muscle pain or diffuse? Because if it's localized, it could be due to infection, it could be due to trauma, inflammation. If it's diffuse, we'll think more about metabolic disease, endocrine disease, systemic disease, autoimmune. The differential diagnosis will be different in your mind a little bit. If we think about or we want to classify the joint pain, we can also classify it as a monoarticular pain or polyarticular pain. So, and Dr. Sami will talk more about the polyarticular pain, which could be more systemic due to systemic condition or autoimmune. The monoarticular, it's different, the causes and differential diagnosis when it comes to age, different from young to old patients. So all of these factors should be in your mind while you are thinking about differential diagnosis. So after finishing or thinking about the differential diagnosis in this broad way, we can proceed now to history, which I consider it 90% of the assessment and 90% of reaching diagnosis, specific diagnosis for musculoskeletal pain is by taking detailed, comprehensive history. So again, it's very important to start with the age of the patient, because we know musculoskeletal pain or causes in pediatric is a little bit different than adolescent, which is more mainly about sport, about activity, and adults is different than geriatric, where the inflammation and degenerative disease is more annual. Then after that, we proceed to pain. And as we know, we have 10 questions to be asked in pain while we ask about pain. And the most important question, which is the duration, is it acute or chronic? Is it sudden or gradual? Location, is it unilateral or bilateral, anterior, posterior, lateral, medial, localized or diffuse? All of these will guide you according to the structure of the joint and according to the location of the pain. That's why remembering and keeping in mind the anatomy is very important, and it will guide you in your decision. Asking them also about aggravating and relieving factor is very important. So the pain is at risk or with movement or an activity. Asking about the associated symptoms, also very, very important. If the patient has swelling, redness, this will lead you mainly to inflammation, instability, or other joint involvement. Is there a fever? So you can think about infection. Is there any muscle weakness, impaired movement, cramps, constipation, diarrhea? All of this will take you to systemic or endocrine disease. And fatigue, numbness, depression, skin changes, weight changes, all of these can be related to other systemic disease or other differential diagnosis that can lead to pain. The third important point in the history is asking or taking a proper history about trauma. And when we ask the patient about trauma, it's very important to ask about the mechanism of trauma. Is it direct? Is it strain or sprain? Because even the mechanism of trauma will change the thinking about the possible cause of the possible affected area in the joint or in the muscle. Asking also about the sport, very important, is the patient is playing any kind of sport and what kind of sport he is playing. And also don't forget to ask about any chronic condition, like maybe the patient is already having rheumatoid arthritis, or he has hyperuricemia, sickle cell hemophilia, or thyroid disease. All of these are factors that can lead to muscle pain. Also, family history of rheumatological and hematological disease is very important. Some risk for infection, like dental procedure, high-risk sex, wound, dysuria, conjunctivitis. All of these can be part of the conditions that lead to muscle pain. Past history of any musculoskeletal surgery or procedure. Occupation, very important, that require repetitive stress and use, such as a construction or farming. All of these can be a cause for the musculoskeletal pain. And it's important also to ask about what are the medications that the patient taken, as we mentioned in the previous slides. Some medication can cause muscle pain, like statin, and also vaccination, which is a rare cause that we don't need to concentrate more on vaccination, but asking the history about medication is very important in evaluating the musculoskeletal pain in your patient. We know that systemic steroid can have been linked to osteonecrosis, and two high-risk groups for osteonecrosis include renal transplant patient and person with SLE. Cases of knee pain associated with the use of statin in combination with phosphodiesterase 5 inhibitor also have been reported. Fluoroquinolones and retinoid have been reported also to cause knee pain in children and adolescents. Regarding vaccination, there are several case reports of new onset of rheumatoid arthritis with knee involvement in adults after receiving anthrax vaccine, which is rare, and when nobody is now, at least in the country, receiving this vaccine. In addition, there is a case report of right knee reactive arthritis 2 days following the tetanus vaccination. An important part of the history and an important part that as a family physician you shouldn't forget, which is the eyes. Idea, concern, expectation, and effect. We need to know, well, what is the patient's information beliefs about the problem, what make the patient worry about his problem, what are the patient expecting from you and why he came to your clinic. And it's very important, as I mentioned in the previous slide, to know and ask the patient about the effect of this pain, whether it's acute or chronic, on his life, on his family, and on his job. So mostly our patients are expecting from us when they come to the clinic, especially in family medicine clinic, they will ask if they're expecting to have just painkiller, okay? Or they are coming directly and asking, doctor, I have a chronic back pain, please just go and order, please, MRI for me. And sometimes they will come directly if they are obligated to go to primary health care to be referred to the hospital. So they will come just asking for referral to orthopedic or rheumatology. And I had a very nice, interesting, very interesting case regarding a patient asking for painkiller, and I want to share it with you from my practice, just to be more aware and to pay attention to musculoskeletal pain and certain patients. So we shouldn't just take it lightly. Musculoskeletal, as I mentioned, it could be something simple. It could be a sign or symptoms, a sign for a serious disease. So this is a 65-year-old male patient. He just presented to my clinic on a wheelchair, and I was wondering why he is on wheelchair. So I asked the patient, why you are using the wheelchair? Do you have any chronic problem? He said, no, but I have severe back pain, which is almost for the last month. And I just came to you just asking for a painkiller because I have this pain. I cannot tolerate the pain. So I just need a painkiller, okay, just to relieve the pain, and that's it. So the patient, in short, he has a past history of prostate cancer 5 years back, and he was treated from this. And by asking the patient about the pain, he all of a sudden he just stand and he was active, and he told me, no, the pain is not in the lower back, the pain is in the upper mid back. So this made me worry more, because why a patient like this, an active and is having a chronic pain in his mid back, and he's 65-year-old with past history of prostate cancer. So I took the permission from the patient. I started my general examination. So I found that the patient has unilateral leg swelling. I asked about the leg swelling. He doesn't know the cause. So the suspicion was high for DVT. I ordered an ultrasound for him. So the ultrasound showed that the patient has DVT. Again, I would remind you about the case. The case was a patient presented to your clinic with almost subacute or chronic upper back pain. So by having the history of prostate cancer, and he has almost chronic or subacute back pain, it could be chronic, we don't know. So I ordered an X-ray for his back, okay, for thoracic X-ray, and the result came to me that there is a lytic lesions in the thoracic vertebra, so it could be a metastasis of the prostate from the prostate cancer. So the learning points from this, or the lesson from this case is that we shouldn't take any musculoskeletal pain lightly. We need to go farther and to examine the patient properly, to take deep history from the patient. Sometimes it could be, as I said, a simple case. Sometimes it could be a serious one. For this one, this was a case, one of the cases from my clinic, and really it was a lesson to me that we need always to have a comprehensive examination for our patient. So going back to the concern, so what makes the patient worry about their problem? So it may be because the pain affecting their work, and maybe the pain will prevent them from sport, or because of the severity, chronicity, and the response to treatment. So the patient will worry that it could be something serious. Also, we shouldn't forget the hidden agenda, asking the patient clearly, is there anything else you want to ask, add, or discuss? Please tell me about it. Very important to ask this question at the end of your history. Patients sometimes are shy or forget, or they don't know that you can help them in their problem. The aim is to explore any extra important information and trying to help the patient to the max. At the end of your history, it's very important to summarize the history and to give feedback to the patient, and this will ensure shared understanding between you and your patient. So I will mention here some interpretation. So if the patient has a muscle cramp that is often not found with the pain, okay, you need to think about some structural disorder as flat feet. It could be a neurological disorder like Parkinson's. It could be dehydration. It could be electrolyte abnormality and others. So you need to think about other causes why once you have a muscle cramp associated with musculoskeletal pain. Another interpretation, pain associated with muscle weakness, you should think about neurological disorder. Distribution of the muscle pain is very important because, for example, statin-induced myalgia typically present as proximal symmetric muscle weakness and soreness. By contrast, diffuse muscle pain, fever, headache, malaise, and non-productive cough are typical for viral infection and influenza. Muscle pain and stiffness in the morning is highly suggestive of polymyalgia rheumatica or other inflammatory arthritis. abrupt discontinuation of SSRI with a short half-life may cause significant pain, and here comes the psychological part. Muscle symptoms that follow the administration of new medication should prompt the clinician to consider drug-induced muscle pain. Also, prior history of mood disorder or depression raised the probability of psychological cause. Low serum cortisol or 24-hour urine cortisol and or abnormal ACTH stimulation test can lead to, or let us think about more about adrenal insufficiency, acute onset of proximal myalgia, morning stiffness, patient over 55 years with high ESR, prompt improvement with low dose steroid, raised the probability also of the polymyalgia rheumatica. Patient with tender points, restorative sleep, fatigue, normal test result also raise the possibility of fibromyalgia. Severe pain without inflammatory finding, often in patients with recent trauma, could be a compartment syndrome. So now going to examination, and which is an important part in our approach and our evaluation for musculoskeletal pain. And why it's important, in my opinion, because number one, sometimes we are ignoring, we are just missing this part. We are sometimes depending on the patient history and what the patient is telling us, and sometimes there are or serious signs that you need to discover it while you are examining the patient. But other than this, other than helping you in reaching your examination, again, I would remind myself that as a family medicine, you should have a comprehensive approach. It's not about reaching the diagnosis. Examination by itself, it's a part of the communication. So you are in communication with the patient physically while you are examining the patient, and verbally while you are discussing and clarifying and describing to the patient what are the findings during the examination. And at the same time, it's reassuring for the patient. The patient will feel that he is satisfied and reassured because just having examined by his physician. These are very important steps while starting the examination. First of all, you need to take permission, and of course, don't forget hand hygiene. It's very important to explain to your patient what you will do and why you need to do certain examination, and also the patient, as we know, has the right to agree or refuse. And please, at the end, it's very important after you finish your examination directly, give the patient feedback about the finding. So there are some tips for productive examination, as we can see here. It's very important to observe at the beginning the patient posture, ability to be weight, gait, and how they move the affected extremity. It will give a hint about the diagnosis. You need to expose and compare both joint. Don't expose and just examine the affected joint alone. You need to expose both joints for comparison. Make the patient comfortable, and this helps to ensure a motion that is as natural as possible. Use patient history to guide your examination. Perform the examination symmetrically, and at the end, don't forget the vital signs and the general examination. So this slide will summarize all the steps for any musculoskeletal examination, whether it's for any joint, for the shoulder, for the knee, for any joint. So always we are starting with an inspection, followed by, of course, there are many details under each of these steps. So starting with inspection, palpation, active and passive movement, then proceeding to joint examination and joint stability for the ligaments, and examining the tendon. And there are special tests for certain joint, like the shoulder joint has special tests. The knee joint, for example, has another special test. Don't forget the neurovascular examination and to examine joint above and joint below at the end. So let us have some interpretation from our examination. Each joint, as we said, examination has its own interpretation, whether it's the knee, whether the knee, the back, the shoulder, and other joint. So if the patient is having fever, you need to think about it could be infection, bacterial or viral. It could be sepsis if it's the patient is presenting with unilateral or swelling, uniarticular pain and swelling and turbulence and all the sign of inflammation with fever. So this is a sign of sepsis. Patient presenting with musculoskeletal pain or joint pain with hypotension. Again, this raises the flag of sepsis. Patient with hyperpigmentation and postural hypotension, it may be a sign of adrenal insufficiency. If you need to pay attention for any cutaneous lesions such as those found in SLE, vasculitis, Lyme disease, psoriasis, and if there is any ecchymosis which can indicate recent trauma. Patient with multiple joint inflammation, it can indicate that or raise the probability and possibility of rheumatoid arthritis, psoriatic arthritis, and SLE. Tendon tenderness with more limitation of active motion than passive motion. It could be because of bursitis or tendinitis. Tender points, okay, can raise again the probability of fibromyalgia or myofascial pain syndrome. Severe focal muscle pain, again, it can be due to one of the causes here, one of the serious causes here that we need to keep it in our mind: muscle infarction or compartment syndrome or myositis. Delayed relaxation of reflexes could be due to hypothyroidism. Regarding investigation, we need to ask ourselves, do we need to order investigation or not? Okay, sometimes it's a simple trauma or sprain, okay, that doesn't need any investigation. If you want to order any investigation, you need to explain the following to your patient, what you are going to order and why, and when he can perform it. For mild symptoms, watchful waiting without laboratory evaluation may be appropriate, as symptoms often resolve on their own with time. Here are some of the initial investigations that can be ordered with certain patients, like CBC is R-reactive protein to see if there is infection or inflammation, vitamin D in certain cases, magnesium, calcium, electrolyte imbalance because associated with severe muscle pain or spasm. Thyroid function test, as I mentioned, it can be one of the causes. According to, you can order it and keep it in your mind, guided by the history and examination, and finally CK. And here are some advanced investigation, and these can be kept to our colleague in rheumatology or another specialty. So this is for our information. So morning serum cortisol or SATH stimulation tests are helpful to diagnose or rule out adrenal insufficiency. ANA for suspected SLE, ANCA for suspected NCA-associated vasculitis, rheumatoid factor, anti-CCP for suspected rheumatoid arthritis. Do we need to order some radiological investigations? Sometimes we need that, X-ray. Maybe sometimes we order X-ray for if we suspect fracture or for acute pain, and sometimes also for degenerative pain. Ultrasound if we have a focal or localized swelling. MRI mostly for chronic condition, and if we suspect any soft tissue damage. Neurophysiology study like EMG may be helpful to support the diagnosis of inflammatory or metabolic myopathy as well as neuropathic process. Tissue sampling like aspiration and biopsy, of course, this will be done by our colleague in rheumatology and other specialty that may help in some certain cases as it's mentioned here. So now we'll end by talking about the management. And when we talk about the management of musculoskeletal pain in general, it's not about treating or controlling the pain. Also, it's not about treating the cause. It is both. We need to treat and we figure out the cause and treat the cause. At the same time, we need to control the pain, especially if the pain is chronic, because as I mentioned previously, the pain is not about the physical. It's not the physical pain. It's just, it can affect the patient physically, psychologically, okay, it can affect his life. So we need to control the pain as much as we can. And if we don't have the facility or we don't have the capability or if we are not competent to control the pain, we can refer our patient for the pain to the pain center for more let us say better control of his pain. So As we know, family medicine, we have what we call the CRAP-PRIOP, which is steps for the management. It's very important to start always with clarification. The patient deserves from you to clarify the problem for him. Avoid details sometimes, okay, and just explain it in a simple way, in simple language. You can use different method like drawing, showing through iPad or videos, and or sometimes giving prepared material. Reassurance, always here we are not talking about premature reassurance. It's about the nature. We are assuring the patient about the nature of the problem and prognosis, availability of the proper investigation, availability of treatment and medical care, and availability of us for follow-up. Non-pharmacological treatment can be used initially, like ice, joint support, advising the patient to avoid certain activities. The next step, we can prescribe some medication for our patients. So when you prescribe a medication, you need to ask what medication you will ask yourself what medications you will prescribe. And it's very important to discuss the options. We have many options. So it is about the shared management between you and your patient. So you need to discuss it with your patient. And why you will prescribe a certain medication and what are the possible side effects. Very important point here, if medication-induced muscle pain is suspected, a trial of the medication is granted, though only after balancing the clinical improvement gained from such a trial with the risk of stopping the drug. Also, don't forget to consider contraindication and therapy. Here are some, some treatment options for pain generally, which fall in 5 or 6 categories. Okay, pharmacological, physical medicine, behavioral medicine, neuromodulation, interventional, and surgical approach. The major category of pharmacological agent for pain management, as we know, starting with simple medication like acetaminophen, or paracetamol, muscle relaxant, non-steroidal, as we can see here, in the oral form, in the gel form, or in the patch form. Antidepressants sometimes can be used with a certain patient with a certain problem. Antidepressant, anti-epileptic drugs, opioid. These are the main category of pharmacological treatment that can be used. Choice of therapy depends on whether the patient is neuropathic or nociceptive. Neuropathic resulting from damage or a disorder affecting the nervous system. Nociceptive, in contrast, caused by stimuli that threatened or provoked actual tissue damage. So as we said, for nociceptive pain, we can use the acetaminophen, the steroidal, opioid. For the neuropathic, we have more than one option, as we can see here: gabapentin, pregabalin, cymbalta, amitriptyline, tramadol. If you are competent to use it, it's one of the options. Referral, it's very important to ask yourself where, why, and when you will refer. Okay, is it a routine referral or urgent or immediate referral in certain cases with severe infection or trauma, or if you are suspecting sepsis? Here are the specialties that you can refer to them, starting with rheumatology, especially if the pain is chronic, diffuse, okay, the possibility of systemic or autoimmune disease is high. Orthopedic, pain clinic is one of the great option, okay, if it's available in your institution. Physiotherapy, okay, sometimes we don't have the authority from primary care to refer to physiotherapy directly, but it could sometimes it is through the orthopedic, and I think this is an area for improvement, an area that we can give the privilege for the family physician to refer directly physiotherapy if they are competent to do that. Chiropractic, sometimes we are referring to them if there is indication. So observation, sometimes, of course, we need to follow up your patient. So you need to arrange follow up your patient and explain why you need to do the follow up. Don't forget health promotion and prevention. It's an opportunity that the patient is presenting to your clinic, so you can do some health promotion like smoking cessation or talking about obesity, which could be one of the risk or causes of the pain. I will give a simple, quick, practical example about joint pain. One of the most common presentation in our clinic, which is plantar fasciitis. Here, the pain is patient presenting with a pain in the lateral plantar region of the foot that is worsened when initiating walk. The peak incidence occur between 40 and 60 years in the general population, with a younger peak in runner. It may be bilateral, sometimes it's unilateral. The diagnosis is based on the history and tenderness and in the area of plantar fascia. And here is the simply, I will not go through the details, okay? Simply, there is many techniques, but this is simple one by dorsiflexion, doing dorsiflexion and pressing in plantar fascia. There will be severe tenderness on the patient, and most of our patients, they are describing the pain that is worse mainly in the morning, okay? So it's mainly a clinical diagnosis. And in general, and this is a simple example of all the comprehensive management that we talked about, the patient need more clarification, education about the nature of his problem, starting with simple things like stretching, exercise, avoiding certain shoes, avoiding certain movement or lifestyle, okay? You can give some medication. Joint support also has a role in in plantar fasciitis treatment. Shockwave therapy, one of the new modalities, it's actually it's not new, but it's new for family medicine that can or has a great help in plantar fasciitis. At the end, injection and surgery will be the last option for your patient. So I will end by the slide. So the recommendation from all of these slides from my presentation, I have more than one recommendation for family medicine. So musculoskeletal guiding approach, I think we need to have a guiding approach in collaboration with our colleague in orthopedic and rheumatology and pain center and other department. Pain management courses and fellow, okay, can be an option also or recommendation. Pain management center and at least in referring institution, availability of the medication and giving the privilege and authority to family medicine physician to control the pain and to increase the satisfaction of our patient. And this is an important part in the management, providing and having multiple educational material for the shoulder, for the back, for the knee, for example, as I mentioned, plantar fasciitis. I think it will be a useful tool in your clinic. Having a shockwave machine, it's a very simple machine and that needs very simple training that can be, I think, can be applied in the primary healthcare, and it will be so useful for family medicine practice. Having a fitness approach, as in IMC we have fitness approach, and really it's, having this kind of service is so helpful for our patient. Having a training about exercise prescription. We are, alhamdulillah, we are maybe good in medication prescription, but sometimes we are not competent and confident enough to give exercise prescription to our patient. And my last point here is the complementary medicine like cupping therapy, acupuncture, acupressure, all of this an area for research, all of this an area for, I think, discussion, okay, because our patients are using such complementary medicine, and I think keep it in our mind and trying to talk about it, trying to discuss it, trying to do some research about it. I think this is an area for research, an area for discussion. Thank you so much, and I hope my presentation was helpful, practical, comprehensive, and met your expectation. Thank you so much.
Thank you very much, Dr. Badr, for this wonderful presentation, which was very illustrative, very elaborative, and you have touched very important points related to our practice. So you brought the real world evidence into practice. So thank you very much on behalf of all the audience. And in fact, I have received a lot of questions, and it seems that you have answered most of it during your presentation. However, we will have a good number of questions for you to highlight certain part of the concern of our audience. So with this, ladies and gentlemen, dear colleagues, I would like to move to the second session in order to be on time. So we have been privileged to have Prof. Sami Bahlas with us tonight. He's a well-known figure in rheumatology, and we have been experienced a lot of support from his side to support the family medicine activities with his expertise. So he's our partner, in fact, you know, from different level of practice. So I think he will add a lot of value for us today. So his presentation is going to be about the approach to adults with the polyarticular pain. I think this is another interesting topic. So it will be added on what has been said by Dr. Badr. So with this, we will have a very comprehensive topic. So, Prof, the floor is yours.
Thank you very much. Do you hear me?
Yes.
And you can see the slides?
Yes, we can see. Thank you.
Okay, thank you very much. I would like first to thank the organizing committee for giving me this opportunity to talk to you and to talk to the family physicians, our colleague in the first line, to see the patients. I would like also to thank Dr. Badr for his very nice comprehensive talk about pain. My talk today will be about approach to adults with polyarticular pain. So if a patient comes to my clinic complaining of joint pain or hand pain, what would I think? Hand pain, ankle pain, any pain. So what would go through my mind? Actually, what I would think is the cause of pain would be either from the joint, from the bone, from the soft tissue. Is it neurological pain? Is it vascular? Or is it referred from another joint? From the joint is mainly arthritis, and this is what we look for as rheumatologists. But it could be from the bone, like osteomyelitis or fracture. It could be tendinitis or osteomyelitis or cellulitis. It could be like, for example, in the hand, carpal tunnel syndrome. They can present with hand pain. It could be ischemia. It could be referred from another joint or from another organ. It can present as joint pain. This is what goes through my brain when I face a patient with joint pain. I'm looking for arthritis. Arthritis is inflammation in the joint. This will cause severe pain and swelling and redness. Persistent inflammation will lead to structural damage and change. This will lead to deformity, inability to use the joint properly. So the patient will not be able to open bottles. He will not be able to button his clothes, dress or undress. This will lead to disability. This will lead to job loss, and there is also systemic involvement of the eye, involvement of the lung with a lot of our autoimmune diseases. There is one study that showed, for example, rheumatoid arthritis, if they were not well controlled, if they have moderate disease activity, up to 50% of them will have job loss. It's a large number of patients. So complete history is the most important skill that we have to reach to our diagnosis. It should be complete, starting with the personal data. We should go over everything. For example, review of systems. If the patient have diarrhea and you have joint pain, this could be enteropathic arthritis. If the patient has UTI, it could be reactive arthritis. If the patient has frothy urine, it could be lupus with proteinuria. For example, the patient might have joint pain and swelling, and he has family history of psoriasis, and this is the only clue to diagnose psoriatic arthritis. Menstrual history is important. The patient may have multiple abortions, and this will give you a clue about anti-cardiolepin antibody syndrome. Again, complete exam is important. It should be a general exam. So all systems should be examined, and as rheumatologists, we concentrate on the musculoskeletal exam. We look at the joint, inspect at rest, we inspect movement, we inspect function, and then we palpate. This is the scheme of our joint examination. In summary, you inspect at rest, inspect movement, inspect function, and finally palpate. Inspecting at rest, looking for swelling, inspecting at rest, looking for erythema, and these are signs of inflammation. Then loss of function is a sign of inflammation. Palpation, you will find warmth and tenderness, which again are signs of inflammation. If all these are present in a joint, so the patient has arthritis. If the patient has arthritis in more than 5 joints, this is polyarthritis. It's if it's between 2 and 4 joints, it's polyarticular or oligoarthritis. So inflammation, redness, swelling, decreased range of movement, loss of function of more than 5 joints. This is polyarthritis, and we can imagine how the patient would feel if he has decreased range of movement and loss of function of more than 5 joints. He will be suffering. He cannot perform a lot of duties to take care of himself, and he will be disabled if this was not diagnosed and treated early. So if the patient have pain, is this articular or periarticular? Articular, usually from the synovium or the capsule, and the pain is diffuse and deep, and the pain usually is on active and passive movement, while the periarticular, the pain usually is on active movement, and there is usually swelling if the patient have articular cause of pain. If the pain because of inflammation of arthritis, usually they have morning pain with swelling, with erythema, that's warm, with significant stiffness, systemic features, high inflammatory markers, and if we aspirate the joint, it will be inflammatory, while if it's the pain is non-inflammatory, usually they have pain, usually during function or in the afternoon, and the swelling is bony, and there is no signs of inflammation, and if we aspirate the fluid, usually it's not inflammatory, and the white blood cells is below 200. If the patient have inflammatory cause of pain, usually they have significant morning stiffness again, they have systemic manifestation, fatigue, and the pain improves with activity, it is worse with rest. They have systemic manifestations, they could have lung, eye, other system could be involved, and usually they improve if they take steroids, and the opposite for mechanical pains. So if the patient have polyarthritis, our differential diagnosis, it could be post-infectious, it could be gonococcal, meningococcal, Lyme disease, rheumatic fever, bacterial endocarditis, it could be post-viral, and inflammatory diseases like rheumatoid, GRA, lupus, reactive arthritis, psoriatic arthritis, polyarticular gout, and sarcoid arthritis. Putting in mind these patient has arthritis, our diagnosis is that there is inflammation in more than 5 joints. When we have involvement of multiple joints, we have to think of the temporal patterns of involvement. So is it migratory, is it additive, is it intermittent? Migratory, it moves from one joint to another joint. One joint is affected, inflamed, swollen, red, then it all resolves, then it moves to another joint. The typical example here is the rheumatic fever. Additive, one joint is affected, swollen, red, inflamed, and then another joint is added. And typically, rheumatoid arthritis is here. And it could be intermittent, which is gout usually as intermittent arthritis. Distribution of joint involvement is very important for our diagnosis. For example, symmetrical polyarthritis of small and large joints. We have to think mainly of rheumatoid, but also viral can be here, and lupus. If it's asymmetrical oligoarthritis involving the lower limbs, reactive arthritis is typically here. If it affects mainly the distal interphalangeal joints, we have to think of psoriatic arthritis. So distribution of joint involvement does help us in reaching our diagnosis when we examine the patient. And this is an example of how we reach diagnosis by distribution of joint involvement. So for example, rheumatoid arthritis, it's symmetrical polyarthritis affecting small and large joints, peripheral joints, upper and lower. And for example here, the reactive arthritis, it's asymmetrical, oligoarthritis, usually oligo, large joints, usually peripheral, and usually affecting lower joints, lower limbs more than the upper limbs. Viral arthritis usually affecting young patients, and usually they have prodrome, they have rash, fever, fatigue, they have history of contact with a sick patient who have viral infection, and they present with polyarthritis that is very similar to rheumatoid arthritis. And it can be confused to rheumatoid arthritis. That's why when we see a patient with polyarthritis that is consistent with RA, we don't rush into diagnosis, and we wait until the patient completes 6 weeks before diagnosing rheumatoid arthritis. Usually they have good prognosis and they improve spontaneously. And the best example is parvovirus P19. It presents exactly like rheumatoid arthritis. And it's called, the virus is called the 5th disease, and they have erythema infectiosum. Usually the children, they have slap cheek, And the adults, they have flu-like illness with rash on their extremities. And joints are more affected in the adults, not usually in the children, and they usually present with abrupt symmetrical polyarthritis with stiffness, and usually in young females that are exposed to kids with erythema infectiosum. And usually it persists for a few weeks to few months, and it disappears spontaneously. This is how it looks. It looks exactly like rheumatoid arthritis. And we can see this is the typical spindle shape of this joint, and this is inflamed. It is swollen, red, and I'm sure this patient cannot flex this interphalangeal joint. And it affects mainly the proximal interphalangeal joints, as we can see here. Rubella arthritis or German measles affect women who are exposed to school-aged kids. Arthritis is common, and they have rash with constitutional symptoms, and usually it is symmetrical inflammatory arthritis of small and large joints. Then we have rheumatoid arthritis. Rheumatoid arthritis is our common inflammatory arthritis disease, usually present with symmetrical inflammatory polyarthritis affecting small and large joints. It can be acute in minimal 10 to 15% of patients, but usually it is insidious, slowly progressive disease. In more than 90% of patients, the hand is affected, affecting the metacarpophalangeal joints usually. And if it's not treated properly, it can lead to hand deformity. But before, in the first initial presentation, before deformity, they have fusiform swelling of the fingers because of swelling of the proximal interphalangeal joints. And as we all know, rheumatoid arthritis is a clinical diagnosis. We use our clinical skills for history and exam, and we can reach with confidence to the diagnosis of rheumatoid arthritis. These are the 2010 American College of Rheumatology criteria to diagnose rheumatoid arthritis. Joint distribution, we can see if it's more than 10 joints, the patient will score 5 points. If they have positive RF or ACPA, if they have high, they will score 3 points. If the symptoms is more than 6 weeks, he will score 1 point. If he has high or ESR or CRP, he will score 1 point. We need at least 6 points to reach the diagnosis of rheumatoid arthritis, and we can get 5 here only from the joint distribution if the patient have more than 10 joints. And this is how the hand looks in rheumatoid arthritis. Again, it's spindle shape, affecting mainly PIPs. It can affect the MCPs also. And the MCPs, usually we can see the swelling here in between the knuckles. If it's inflamed like here, the swelling in proximal to the knuckle, proximal and between the knuckles. Sarcoid arthritis, sarcoidosis is a chronic inflammatory non-caseating granuloma is usually found in the affected site. Up to 20% of the patient, they have symmetrical arthritis, and they usually have lymph nodes, they have erythema nodosum, and we have Lofgren syndrome, which is acute arthritis, usually affecting the ankles with erythema nodosum and hilar lymph nodes. And this is how the sarcoid looks, the hand, how it looks. We have reactive arthritis, which is an arthritis that comes after an infection, few weeks after infection. Usually there is association with HLA-B27. They usually present with asymmetrical oligoarthritis, affecting usually the lower limbs, and it can affect the spine with sacroiliitis, with inflammatory back pain. Enthesitis is typical here, which is inflammation of anything that is attached to the bone, and usually the Achilles tendon is one of the tendons that is inflamed in reactive arthritis. They can have extra-articular manifestation because it's a systemic disease, so they can have rash, they can have eye involvement. And we can see here, this patient knee, this is the normal knee here. We can see the groove. There is no effusion here, but the groove here is lost, and there is actually swelling, and this patient have arthritis of his knee, and because of reactive arthritis, it's asymmetrical. It affects only one side. This is the normal Achilles tendon, but this is swollen because of Achilles tendinitis. And the pathology here is enthesitis that happens in reactive arthritis. This is keratoderma bilirubicum, typically affecting the soles and the palms, and this happens in reactive arthritis. They can have eye involvement, they can have mouth ulcers and erosions. Then we move to psoriatic arthritis. Psoriasis affect around 4 to 5% of the population, and up to a third of the patients of psoriasis, they have psoriatic arthritis. And dactylitis is one of the typical manifestation of psoriatic arthritis. They present with sausage fingers, and also nail changes is important to look for in patients who have psoriatic arthritis. We classify it into subtypes. Asymmetrical oligoarthritis was the commonest, and it can be like rheumatoid, and it can be with algal involvement. These are the nail changes of psoriatic arthritis with dystrophic nails.
Prof, we have 3 minutes.
3?
3 minutes.
Okay. This is dactylitis, and this is the rash of psoriatic arthritis. Lupus is a systemic disease, and they present with arthritis but without erosions. It's a systemic disease. They can have malar rash, alopecia, and these are the American College 2019 classification criteria for lupus. They can present with malar rash, sparing the nasolabial fold, and photosensitivity and hair loss. Rheumatic fever, they can present also with migratory arthritis. Here, the mistake is that ASO teeter and arthritis is not rheumatic fever, and usually it affects younger patients. This is the rash of rheumatic fever. It's cercinate rash with central pallor, serpendious rash, and they can have subcutaneous nodules. Gouty arthritis also can present with polyarthritis. Skin lesions can help us in the diagnosis of arthritis. We have the psoriasis, we have the vesicles, the pustules in gonococcemia, keratoderma. We have erythema marginatum and rheumatic fever. We have also in adult onset Still's disease. This rash appears with the fever. We have with lupus. Lupus typically appear in between the joints in the hands. Keratoderma again, erythema nodosum. Tenosynovitis can help us also in diagnosis of our arthritis. We can see it here in JRA, swelling here, and also in psoriasis and enthesitis in psoriasis or reactive arthritis. Eye also is affected here. Also oral ulcers and nail changes and hair loss can help us. Nail pitting, typically in psoriatic arthritis, onycholysis. So we need complete history and complete exam. We have to go over all the system. We have to confirm the presence of arthritis, know everything about the arthritis. We do need basic investigation. We should not forget urinalysis if we think about lupus. Synovial aspiration is not usually done, but if we do it, we usually do it for gram stain and to see if it's inflammatory or to look for crystals. CCP and RF if we think of rheumatoid, and then lupus. HLA-B27 is done if there is sacroiliitis, if we think of rheumatoid, and we think to treat with methotrexate or biologic, we need to do this test. And thank you very much.
Okay, Prof. Sami, thank you very much for this highly professional, detailed presentation that put things in its perspective. I personally learned a lot out of it today. So ladies and gentlemen, dear colleagues, I would like to move to the third speaker, Dr. Tamer Harbi. He's the product manager of Asino, Saudi Arabia. He's going to talk to us about today about the acute pain management between the efficacy and the safety. And this is actually a huge dilemma for us. whether to be very effective in your treatment, but at the same time, you have to ensure the safety of your patients and not to get into the complications. So making the balance this is what we are going to learn today from Dr. Tamer. Dr. Tamer, the floor is yours. Please go ahead.
Thank you, Dr. Ashraf, for this. Thank you, Dr. Ashraf and Dr. Sami and the faculty member for letting us to take the opportunity to be with you today and to discuss this important topic about acute pain management between efficacy and safety. I'd like to talk firstly about Asino as a healthcare. Asino is a Swiss pharmaceutical company headquartered in Zurich. We develop and manufacture an internationally market-well proven and innovative pharmaceutical in novel drug delivery forms. Today, I'd like to ask one question already discussed in the previous presentations. What is the main cause for any patient to visit any clinic? We will find from the two presentations we discussed from Dr. Sami and Dr. Badr, it is pain. And we would like to take an overview about worldwide pain facts and the pain statistics, acute pain statistics. It is a global burden pain. We will find nearly everyone requires painkiller at some point of their lives. More than 50% of people will have experienced acute pain in the previous 3 months. Women are more likely to experience pain than men. Acute pain accounts 7 out of 10 patients in emergency department visits, and more than 50% hospitalized patients report acute pain. There also socioeconomic impact acute pain, as Dr. Sami said in his presentation, as limiting participation in favorite activities, impeding routine tasks, prevent enjoyment and leisure and family time, and also interfere with sleep, which make a depression and anxiety and significantly healthcare burden with a lot of work absence, which affect the socio-economic and the quality, and it make a financial burden for the government and the whole country. There is a clinical guidelines from American College of Physicians and the American Academy of Family Physicians at 2020, as they both of them recommend that clinicians treat the patient with acute pain and the musculoskeletal injuries with topical nonsteroidals, with or without menthol, as a first-line therapy to reduce or relieve symptoms, including pain, and improve physical function and improve the patient treatment and satisfaction. From these guidelines, we will talk about diclofenac as a well-established non-steroidals. The diclofenac, more than 30 years in your clinics with clinical experience, used by more than 1 billion in 120 countries around the world. Diclofenac has the efficacy is largely unchallenged. Diclofenac sodium is a benchmark pharmacological treatment of osteoarthritis. We will say that diclofenac as acidic non-steroidal base. We will find the diclofenac has the highest distribution coefficient between synovial and fluid and the plasma. Due to its pharmacological properties, diclofenac preferentially distributes to the area of inflammation, such as the synovial fluid and tissues. And we will find in this graph the reality about the absorption of the diclofenac in the plasma with the orange line, and the concentration of the diclofenac in synovial, which affect the efficacy, and the diclofenac persists in inflamed areas, and it's cleared more quickly from the central compartment, potentially lessening the risk of adverse effect. We will find here the diclofenac concentration in synovial almost about steady state in more than 100. So the diclofenac persists in area of inflammation with less side effect.
Today, I'd like to present the Olfin patch, a new topical formulation for treatment of local pain and inflammation. Regarding the all patient coming to your clinic suffering from low back pain and sprain, strain, sport injuries, with the diclofenac sodium Olfin patch, you will unfreeze the patient life with this topical formulation. When Olfin patch applied to the skin, we will find that the diclofenac penetrate immediately into the skin tissue with an innovative galenic formulation in the convenient form. It is the patch. Here, there is a study between the diclofenac sodium and its reference, diclofenac ibulamine, and its pharmacokinetic study was done to differentiate the concentration in mean plasma concentration and mean standard deviation. We will find here the diclofenac sodium is the upper line, which approximately twice the concentration, mean plasma concentration of the reference diclofenac ibulamine. It means to you and your patient significantly higher transdermal bioavailability of diclofenac in terms of Cmax and the extent area under the curve of drug absorption, which means efficacy of diclofenac to your patient and the constant continuous drug delivery around the clock. Olfin patch has a significantly higher reduction in pain on severity movement after 2 days of starting treating acute soft tissue sport injuries. When we talk about pain reduction, we will find Olfin patch demonstrated 32% pain reduction of acute traumatic injuries in the first 6 hours after treatment initiation. As well as Olfin patch is well tolerated and exhausted a placebo-like safety profile with non-systemic reaction because it's Olfin patch topically applied. So it with lower incidence of adverse effects such as a peptic ulcer and the gastrointestinal hemorrhage due to reduced plasma concentration. It means a lot of safety and efficacy in the Olfin patch. I'd like to summarize Olfin patch offers many advantages for your patient with guarantees adherence. As an Olfin patch acts where it hurts, it is convenient for 12 hours. It fits around joints. Olfin patch, it's 5 patches in a releasable pouch, doesn't stick or stain the clothes of patient. When the patient opens the pouch, he can use it for 3 months when store it at the room temperature below 30 degrees Celsius. Olfin patch offering a wide range of indications. The first one is trauma-related inflammation as a result of sprain and strain, sport injuries. Trauma-related inflammation as a result of dislocation. And lately, the trauma-related inflammation as a result of contusions. When we back to the guidelines and recent guidelines from the American College of Physicians and the American Academy of Family Medicine and their recommendation to use topical non-steroidal as a first-line therapy, we will find unmet need in pain management, especially in the conventional topical formulation in your clinics, as this topical formulation will have not calculated dose, sticking to the patient clothes and easily removed, need more time to dry, and as well they need more rubbing. So it will not convenient to be prescribed and affect the quality of life of the patient in his working, and they need more time to go his work, to practice his daily activities. While in the Olfin patch, we will find the Olfin patch offering 140 milligram in each patch with convenient twice daily application and doesn't stick or stain to the clothes. Lately, I'd like to summarize the Olfin patch as an appropriate skin penetration and effective and fast choice of the treatment of sport impact injuries of inflammation, excellent tolerability, convenient twice daily application up to 14 days, additional cooling effect. And thank you for your attention.
Thank you very much, Dr. Tamer. And I think we have received a good number of questions. And now I would like to open the discussions, and I would like to invite all the panel to receive my questions, which has been highly selected by the audience. The first question is, I think this is the most important part of all our event, is to answer the questions and to address the concern of our audience regarding certain issues. Dr. Badr, the first question is for you. Pain of psychological background. Do you treat with antidepressant, or you treat with non-steroidal anti-inflammatory, or you treat both?
Okay, Bismillah ar-Rahman ar-Rahim. So according to the severity of pain, of course, if the pain is due to psychological cause, okay, first of all, we need to assess the psychological cause. And after that, we should think about, first of all, should we start, for example, SSRI, antidepressant medication, okay, to control the psychological status or not, or the psychological condition of the patient? Because again, are we treating the cause or we are controlling the pain? We are doing both, okay? So we are controlling both. And as we know that SSRI by itself, okay, sometimes it's controlling the pain, not because it's controlling the pain, but because you are treating the cause too, and then after that, it will control the pain. So it's always about treating the cause. Starting with the right diagnosis, you should diagnose your patient as having depression, as having anxiety. If you are competent and confident enough to start such medication, you can start it, or you need to refer the patient at least once to our colleague in psychiatry. Then after that, the patient can follow with you. It is a treatment by itself. It helps in controlling the pain indirectly by controlling and treating the cause itself, okay, if you are sure about your diagnosis. And at the same time, okay, it has an indirect effect by controlling the pain. And we have many cases, and the simple presentation in our clinic, patient coming with severe tension in his neck. He has chronic and severe acute on top of chronic cervicalgia. And when you start to search for the cause, there is no specific mechanical or physical cause, and it's mostly about the stress, it's mostly about the anxiety, okay? And here comes your clinical judgment. Are you going to give something temporary for him, like benzodiazepine or something just to relax his muscle? Then after that, you are going to follow. I think you can both use, you can use both, and then steroidal at the beginning with muscle plus minus muscle relaxant just to control the pain, then treat the cause.
Okay, thank you very much. I think this comes into our clinical judgment, because
exactly.
lower back pain and somatization as part of depression, it's quite common encounter in our day-to-day practice in family medicine. So whatever you use as non-steroidal anti-inflammatory and analgesia, you're not going to avoid the pain, because the etiology of the pain is psychosomatic. So definitely, if you are capable of diagnosing and treating depressions with the safe medications that we have, I think this would be the good remedy for this kind of presentation, which is very common. Thank you, Dr. Badr. Professor Sami, there is a question: what are the common causes of non-inflammatory causes of a small joint pain commonly encountered in primary care?
The common thing that we see is osteoarthritis. The primary osteoarthritis, which affect usually middle-aged females at around age 40, they can present with non-inflammatory joint pain, mainly in the hand, and in the form, if it's exaggerated, in the form of Heberden's and Bouchard nodes. Another cause of non-inflammatory is soft tissue involvement, especially in diabetics if they have tendinitis and flexor tenosynovitis and trigger fingers. This is another cause of non-inflammatory pains of the joint.
Okay, thank you very much, Prof. There is a question for you, Dr. Tamer. Does the diclofenac sodium patches induce the GI symptoms, complications in spite of being a patch, or there is some element of gastroenteritis even with a patch?
Regarding the often patch side effect of the gastrointestinal side effects, there is no gastrointestinal side effect to the patch. As I said in my presentation, it is a placebo safety effect, like a placebo safety effect. So it is a matter of irritation or just hypersensitivity if the patient have sensitivity to the diclofenac or acetyl salicylic acid.
Okay, thank you very much. There is a question from Dr. Muhammad Al-Khatib. The question is for you, Dr. Badr. Can we get the experience of the speaker, it's you, Dr. Badr, on non-pharmaceutical approach like osteopathic and acupuncture, natural nutrients in the management of musculoskeletal pain? You mentioned, Dr. Badr, part of it, but if you just can elaborate based on your clinical experience as a family physician.
Okay, so many patients are coming for us, and they have experienced non-pharmacological therapy, and they have the experience in the pain management clinic with chiropractic. So there are many new modalities which is non-pharmacological, and it's at the same time it's not pure interventional that can really alleviate and decrease the pain. I have some patient with clear diagnosis of fibromyalgia. They get a great benefit from wet cupping therapy and hijama. Other patient they used the special laser treatment, which is not available here now, to my knowledge, in the kingdom. But outside, they did it outside, the laser, okay, with a certain amount of laser, okay, it helps in certain area, and Dr. Sami can highlight on this. I have many patients, as I mentioned, as non-pharmacological therapy, patients with chronic plantar fasciitis. There is amazing result when they are taking at least 6 sessions of shockwave therapy, amazing result. We can use what we call the nerve block through our colleague in the pain management. Again, it gives a great result. With some cases, I'm referring some cases for our colleague in the complementary medicine. They are doing some certain of manipulation when there is a malalignment. So manipulation through what we call the chiropractic, it helps a lot of patients. Okay, I believe in acupressure and acupuncture, but I don't have an experience patient coming and relieved from acupuncture or acupressure. But for sure, the cupping therapy, the chiropractic, shockwave therapy, laser therapy, nerve block, all of this available in some centers, and really it's so helpful.
Okay, I would like to thank the audience because I'm getting a lot of questions in gush, coming all together. And I just want to continue with you, Dr. Badr, questions. Could osteoarthritis be a mixed type of pain, nociceptive and neuropathic pain? And what is the best approach for this kind of mixed type of pain?
Mixed type of pain needs sometimes different modality of treatment, different modalities of treatment. And this is, again, you should weigh the risk and benefit for your patient. If the patient is elderly, has comorbid disease, diabetic with renal impairment, so you'll be cautious in giving the patient a safe long-term or at least short or long-term non-steroidal. Sometimes because most of the patients coming with osteoarthritis, they are obese, okay, they have also a combined, okay, neuropathic pain because of low back disc. Here comes again, and mostly if they are diabetic or not, there is a place for the for giving pregabalin or gabalin or like a Neurontin or Lyrica or other SNRI, which can act on both the nervous system at the same time, the structural cause of osteoarthritis. So we are facing this, especially in elderly, obese patients.
Okay, thank you very much. And I would like to comment here on on top of what you have said, Dr. Badr. This is quite common that we have osteoarthritis, and this is the only one of the few clinical entities that represent the mixed type of pain, which is nociceptive and neuropathic pain. And this is the only type of clinical entity that we can use both. So we can use the first line management of neuropathic pain, which is pregabalin, gabapentin, duloxetine, and tricyclic antidepressant, as well as the non-steroidal. But we have to weigh risk and benefit, and we have to monitor the benefits of the neuropathic pain, because 30 to 50% of reduction of pain will be considered as a good and successful management of neuropathic pain, we should not go beyond that, because most of the patient, they might have the perception of having a complete relief of pain, which is not realistic. Prof. Sami, this is a 1 million question for you, which is a very important question for us. Being our colleague sitting on the other end of the healthcare system and observing our practice as a family physicians, how do you evaluate the quality of practice that we perform as a family physicians when we refer patient to you? Do you think that we handle patient appropriately from the start when we handle them as the first contact and first episode, and then do you think that the patient has been managed appropriately and he reached with you with a proper diagnosis or differential diagnosis? And what is the pitfalls and what is your advice to enhance our capability to be more better? Thank you. Unmute, please, Dr. Professor. Unmute you. You're muted.
Yes.
Okay, go ahead.
Thank you. This is a very good question, and it's a very difficult question at the same time.
I know.
I think the answer will be, it's variable from place to place, from hospital to hospital. But overall, I do appreciate the work and the pressure that is facing our colleagues in family medicine. Sometimes, most of the times, I think they are doing an excellent job, and they are giving us, the patients, with good workup, with clear plan, as if I have seen him the first time. Most of the now, even I would say, even the patients are educated, and they come and they have certain questions. He comes and he says, I have a lot of patients, I'm sure you do have the same thing. Do I have lupus? Do I have rheumatoid? My brother-in-law, he has psoriatic arthritis. My relative, he has ankylosing. Is it the same problem that I have? Such a patient, usually, the answer is clear, and the family physician is doing a good job there. Certain things are difficult for both of us at both ends, at the family physician side and at our sides. The vague patients, the fibromyalgia patients, I think none of us will be doing a satisfactory job there. I think, again, it's very variable from center to center. But what I have seen in IMC is a good job, well balanced, clear, bland, for targeted investigation, not haphazardly ordered. And the advice is the same advice that I advise myself and advise all the colleagues. You have to look to the patient as a whole, look to the whole systems, do a complete history, a complete exam. Don't forget, if you think about lupus, urinalysis, that's something we usually do forget. If the patient have any eye symptoms, we have to refer him right away to the ophthalmologist. Eye is a very important organ and can be affected. Are we okay?
Yes, I'm fine. Yes.
Eye is very important.
Okay.
If there is any problem, refer directly to the ophthalmologist. Thank you.
Okay. Thank you, Dr. Sami. But this will lead us to another question, which is, of course, you know that we are in primary care and family medicine. We try to adopt certain guidelines and clinical pathways, which is, we share it with the subspecialty. Do you recommend any guidelines that could be added on top of what we have here to make our practice quite aligned with the subspecialty, so we can speak the same language of medicine and the patient will move smoothly from primary level to secondary level of care? So do you recommend any guidelines?
I don't know any, and I think the guidelines will not be applicable for primary care. Maybe it will be applicable for ER patients when they present with certain presentation like acute monoarthritis or or vasculitis or something in that sort of emergency presentation. But for family physician, I'm not aware of any guidelines that can be given because I think the presentation sometimes or most of the times is vague, and it depends on the experience, and I'm not aware of any. I hope we find something.
Okay, thank you very much. In order to be in time, I'll have only two questions. One question is for Dr. Tamer. The difference between the diclofenac sodium and diclofenac potassium in terms of efficacy and safety, and which I know this is quite crucial, but this was a question which was asked. Please.
Okay, the difference between diclofenac sodium and diclofenac potassium, it is a salt, as you all know, and it will differ especially for cardiovascular patient, as they were recommended to take the diclofenac potassium, but unfortunately the Olfen patch is available with diclofenac sodium here. There is no diclofenac potassium for topical formulation, especially as we said, there is no systemic adverse event.
Okay, thank you very much. I will close with the last question with Dr. Badr, because this is, again, it's important. So Dr. Badr, if you just can remind us again, what is our limitation in managing patient in the family medicine practice and primary care with acute pain? What is our limitation for which we have to refer patients, and what is the red flags? And with this, we will close, inshallah.
Okay, Bismillah. Okay, always I'm saying to myself and my colleague, your limitation depend on 4 things, and we can add another item at the end. So the first thing is your experience and expertise. This is number 1. Okay, your own experience and expertise in family medicine. Family medicine is one of the specialties that is wide, broad. Okay, so there will be variability of experience, and according to your center, according to your training. Always keep your experience and expertise, number 1. Then after that, and according to the policy and procedure, okay, and the internal agreement in your institution, it make a big difference if you are working in a hospital-based family medicine clinic or in primary care, and according to the internal policy. Third point, which is according to the regulation in the country, and third and fourth point, the international guideline, as you mentioned. Coming back to the red flag, each joint and each complaint or disorder or category of musculoskeletal pain has its own red flag. Okay, and for example, patient coming with fever and sepsis, okay, and very clear inflammation. So this is a clear infection. This is a clear severe monoarticular pain due to sepsis infection. This is emergency directly. Others we cannot specify because each joint has its own red flag. Patient coming with weight loss, patient coming with other associated symptoms, as Prof. Sami mentioned, like patient coming with other inflammatory disorder, other systemic disorder, like patient coming with diarrhea, patient coming with sexual transmitted disease. All of this is, I think, it's out of our scope. I think we should share it. Patient coming with suspected with soft tissue injury. Okay, so this is an indication, or let's say red flag, but an indication to refer to orthopedic. For example, ACL, anterior cruciate ligament tear. Okay, other point, which is the vague symptoms. Okay, patient with chronic pain and he's not responding to treatment. Patient with generalized pain that you don't know exactly. Okay, what are the causes? Vague. I think here comes the place to refer to your colleague in rheumatology, plus minus the orthopedic. This is in general, but keep in your mind always your experience and expertise and the facilities, okay, present in your institution.
Okay, thank you very much, Dr. Badr. And this was the last questions. And there is a message I would like to convey to all the speakers. I received a lot of comments on this presentations and this event, which was really remarkably marvelous and was highly appreciated by all the audience, most of them. So thank you very much for all of you. And I would like to, at the end, to thank our guest speaker, Dr. Badr bin Hamd, Prof. Sami Bahlas, and I would like to thank Dr. Tamer Harbi. And I would like to thank again, also with a special thanks to Dr. Sami Eid for attending our sessions and representing the Saudi Society for Family and Community Medicine. And I believe it will be a very good opportunity for all of you to get enrolled in this prestigious society by applying your applications to the shown email. And I would like to extend my thanks to Asino Company for sponsoring this event, and thanks for Multaqa Al-Khibrat for wonderful organizations. And I would like to thank you all, ladies and gentlemen. Alhamdulillah, we have been privileged to have more than 800 registrations and actually almost 400 attendees. So this is a significant indication that this event was quite important for all of us because of the wealth of knowledge that we have learned. And I would like to ask you to accept our invitation for our next IMC Family Medicine Club, which was going to be, inshallah, next month. So stay tuned and